Hereby, I open this academic ceremony in which Angela Satriano will defend the academic thesis, Vasoactive Agents, Oxidative Stress Markers and Neurotransmitting Monitoring in Congenital Heart Diseases Children, subtitle of Children. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Prorector, dear members of committee, dear family, I'm going to present my study, but before speaking you about the topics, I want to introduce my patient population. Congenital heart disease in Europe have an incidence of that can range from 0.5 to 1.2 live births, and 1/3 of babies are diagnosed prenatally. This is the classification of congenital heart disease. We can divide these pathologies into cyanotic and acyanotic heart disease. Cyanotic one can be divided into other groups, with the one with decreased pulmonary flow and with increased pulmonary flow on one side. On the other side, in acyanotic population, we have left to right shunt lesions and obstructive lesions. In cardiac surgery, we have generally two surgical options. The first one is palliation, more complicated patients that needs several steps before arriving to a normal physiology. And one of them could be correct directly with only one step of surgery. To perform these interventions, we need the support of cardiopulmonary bypass in 98% of cases. CPB guaranteed cardiac output and tissue oxygenation while the heart is stopped by the surgeon to perform the surgery. CPB is strictly related with brain injury, and the incidence is ranging from 1 to 0.5%, but we can see a peak of incidence in the baby who underwent to a period of total circulatory arrest, even if nowadays we perform a selective cerebral perfusion. Risk factors are substantially continuous blood flow, hypothermia, embolism, hemorrhage, hypoperfusion, and systemic inflammatory response. We can use some tools to detect and avoid brain injury during cardiac surgery. The first of all is near-infrared spectroscopy with its limitations, such as hemodilution, tissue edema, skin pigmentation, and so on. We use transcranial Doppler to check the blood flow in the major vessels in the brain, and electroencephalography or a multimodality neurological monitoring. So the aim of my thesis is to evaluate the usefulness of a panel of biomarkers in the hemodynamic and cerebral perioperative monitoring of CHD infants. These are adrenomedulin, S100B protein, glutathione, and GABA. This is the first work, is a review in which we evaluate the potential limitation on these neurobiomarkers, and we reach the optimality score of the perfect biomarker that has to be a direct indicator of central nervous system damage, an early predictor of degree and location, and indicator of extension of brain lesion. Let us to monitor the progression of disease, well studied in pediatric population, easily measurable, and with a reference range in pediatric population detectable in different biological fluids, not only on blood. Adrenomedulin is the first one, is a peptide that is a substantially vasodilator and natriuretic agent, is found in various tissues, is well known related in the patients with hypoxic chronic pathologies, just like COPD or severe chronic asthma. Is a C-amidated peptide that promotes neovascularization in response to hypoxia, and is directly has a direct effect on endothelium with the role in vasodilation. Is well known as a good informator in pregnancies with acute chronic hypoxia or asphyxia and cerebral hemorrhage. The second one is best known probably S100B protein, that is an acidic calcium binding protein identified in Schwann cells by Moore, but the only source of this protein is not only the central nervous system, and it could be a confounding factors also in our studies. For example, another important source is pericardial fat. As a neurotropic action and contrasts neuronal cell death and mitochondrial dysfunction. The third one is glutathione, that is a tripeptide that is substantially an antioxidant, a free radical scavenger, and is involved in the synthesis of leukotrienes and in detoxification of various types of xenobiotics, maintaining the oxidative status and involved in the improvement of cell immune response by activation of lymphocytes. Last but not least, GABA, alpha-aminobutyric acid, is a neurotransmitter that plays a regulatory role on cardiovascular and brain systems. For example, it has been shown to be involved in as an anti-hypertension agent, modulating vasopressin release and analgesia through nitric oxide mediated mechanisms. So this is a table that summarizes all our data, and then emerges that S100B is the first biomarker that has all the characteristics we search on this topic. But if we look better, S100B is really important, but especially for the brain damage. But AM emerges to be really important in GHD related LCOS, low cardiac output syndrome. In fact, the next work I present is the adrenaline alteration related to cardiopulmonary bypass in infants with low cardiac output syndrome. You know, low cardiac output syndrome is characterized by low pressure, low urine output, lactates, metabolic acidosis, and so on. It is strictly related to endothelial damage. We measured the AM levels in 48 patients. 9 of them were affected by LCOS, undergone to open heart surgery with CPB, and we took blood samples at 5 predetermined time points before surgery, during surgery, before CPB, at the end of CPB, at the end of surgery time, and 12 hours after surgery time. Our results were matched with the CPB details, so deep hypothermia, cross-clamping, circulatory arrest, cooling, and rewarming. And our results show that there's a significant correlation among LCOS, AM measured at the end of CPB, and cooling duration. At a cutoff of 27 picograms liters at T2, AM achieved a sensibility of 100%, while cooling at 11-minute cutoff achieved a specificity of 92% for LCOS prediction. So AM monitoring during the perioperative period of these children could be helpful for early identification of cases at risk, is easily measurable and gives result output within 2-6 hours. So AM measurement is to be considered to evaluate the efficacy side effect of the neuroprotective strategies that we are performing. The third study takes in consideration the behavior of the well-known S100B protein as a predictor of ominous outcome in infants undergo cardiac surgery. It's a case control study. We consider 88 GHD infants, 22 were complicated by perioperative death. We took blood samples at the same monitoring time points. And we note that perioperative S100B levels are increased always in congenital heart disease infants, but in the dead group were significantly higher in all monitoring time points. the multiple regression analysis shows a correlation among the levels of M100B and all the duration of all the phases of cardiopulmonary bypass. And the most interesting data is that at the cutoff value of 0.1 microgram liter, S100B achieved a sensitivity of 100% for death. So preoperative elevative S100B concentration are predictors of ominous outcome at a time when standard monitoring procedures are still silent. The other work that involves the S100B protein is made in a population of 48 GHD infants divided in two groups this time, cyanotic and non-cyanotic, 6 monitoring time points, and our results show that the concentration of the protein was higher from T0 to T0 to T5 in the cyanotic group, and there's a positive correlation between the concentration of the protein and PaO2. So the higher levels of the protein in cyanotic infants are due to an hypoxia-hyperoxia mediated insult, suggesting that these patients are more prone to perioperative stress damage. We need further investigation to detect the optimal PaO2 to avoid the side effects associated with the reoxygenation during CPB. Glutathione blood concentration is the other study topic of my thesis. Is an observational study. Our population in this case is of 35 patients affected by congenital heart disease without pre-existing neurological disorders, 5 time points. In this case, we can affirm that the levels of GSH are higher during the surgical procedure, and there's a positive relation between the duration of CPB and cross-clambic, but a negative relations between GSH and body core temperature, probably for the hemoglobin oxygen curve that depends on temperature. The blood levels of GSH increased during surgical procedure and remain elevated up to 24 hours after intervention. And probably the levels into systemic circulation has to be considered as a compensation of oxidative damage. In fact, the more increase in levels are corresponding to PaO2 peaks. Last but not least, GABA. We analyzed the behavior of GABA in the perioperative period among the two populations of cyanotic and non-cyanotic congenital heart disease. These are 68 babies, 33 non-cyanotic, 35 cyanotic. And in this study, we matched the values of the concentration of GABA in the blood and systemic saturation and cerebral regional saturation. And in our results, we confirmed that in cyanotic population, there's a reduction in levels of PaO2 at T0, T1, and T3, while no differences were observed at T2, T4 time. The behavior of the cerebral region saturation is flat for both the populations, cyanotic and non-cyanotic, with lower numbers for the cyanotic one. This is probably the most interesting finding. GABA concentration was very, very high in babies with cyanosis before the intervention, but the level drops down and goes down the level of the non-cyanotic population during all the other time points after the during the intervention and after 24 hours. So GABA significantly changed during surgical procedure, especially in cyanotic cases, is correlated with the length and different phases of CPB and related to PaO2 and SaO2. So we can conclude that S100B protein can be considered a trustable predictor of CNS stress damage or ominous outcome in this population of patients. Adrenomedulin in CHD children could be helpful for early identification of cases at risk of poor outcome, hemodynamic and neurologic one. GSH levels in these children has to be considered a compensatory mechanism to oxidative damage, to whom they are more prone, and obviously we don't have to leave traditional biomarkers because they are indispensable in assessing brain and myocardial injury, but integrating both and traditional and emerging biomarkers probably is a gain for the physicians, because we can personalize the intervention on these patients, for example, during cardiac procedures, optimizing CPB management in terms of temperature or oxygenation. Future research should aim to standardize the use of these biomarkers because the time is changed. I leave you with a small reflection. In the past, the only important thing for these patients was survive. So don't die because of their cardiopathy. Today, we can do better. We can give them a better quality of life if they don't have neurological and cardiological damage while we are correcting the pathology, because this is important for them, for their family, and for the entire society. Thank you for your attention.
Thank you for this nice presentation. Now we start the opposition, and this will be opened by the chair of the assessment committee. That's Professor Dr. Daniel van der Hoeven. He has a chair in neuroepigenetics at the Maastricht University. The floor is yours.
Thank you. Well, thank you very much, Mr. Prorector. And first of all, congratulations on this very nice thesis, dear candidate. And also my compliments on the presentation, and also my compliments to your supervision committee. Let me maybe first go to page number 57. And actually, you showed the figure also in your presentation. So this is figure number 1. Maybe you can have a brief look.
Yes.
So maybe you can once more explain what we see in this figure to start off with.
Yes, thank you for the question, highly esteemed opponent. And in this picture, we considered the behavior of the concentration in the different phases of CPB, and we can note that at T2 and T3 we have an increasing of S100B, because in this patient population the behavior depends on the cyanotic status before the intervention or not. These babies are not it's not possible to treat them in the same way, and these values and this behavior of S100B can guide us to detect the damage and detect the suffering during CPB. Yeah. For the surgeon, is really difficult to manage the perfusion while he's operating, and have the possibility to detect a suffering of the baby is a good option. When we administrate to this baby sedation is the moment in which they start to suffer, because they pass from an hypoxic chronic status to an hyperoxic chronic immediate status, because when I ventilate a baby that lives at a saturation of 60 and I give him a big administration of oxygen, this is the moment in which he starts to suffer. When I put him on CPB, he goes on to suffer, and when I want to stop the assistance, sometimes the surgeon can see that the heart is not so performing, that is not easy to detach the assistance, and we don't know why sometimes, because the procedure was correctly conducted. So in these cases, these values can help us to re-indicate the management, the circulation, and the surgical procedure in general.
Okay, clear. Thank you very much. Now, you also appreciate, I hope, that there's quite some variation in the levels of S100 beta within groups. So, of course, there's a clear difference between those that eventually die and those that stay alive. But
Yes.
do you think you can use, because you also see that in the controls, those that still survive, did you consider looking into whether this could predict how well they recovered? So do the levels of S100 beta say anything about recovery and prognosis in general? So of course not for those that die, that is clear, but does it provide you with meaningful information for the controls in this case?
Okay.
Is my question.
We controlled the baby, generally our case control study were conducted following Emil Tyson's criteria, and the physician that analyzes the baby is the same before the intervention at 7 days after the intervention. At this moment, something is changed in respect of these results. For example, during circulatory, extracorporeal circulation, the normoxic management is a new tool regarding these findings. So for the restoration to a normal function, we don't have so certain data, but surely the not direct values such as near-infrared spectroscopy or blood lactates or the delay to awake after stopping sedation are surely better when if we could detect these biomarkers, in my opinion, because when we have a baby sedated and put on assistance, we can't check his reactivity, so it's a closed box. Yep. We can discover only when all is finished and we can awake him. Sometimes we had bad surprises. The damage, even if the NIRS was good, even if the pressure was good, no, they don't have a good awake status. So in cardiac surgery, good pressure doesn't mean good perfusion.
Yep. Clear.
So in this case, we can ask and help to biomarkers to let us perform the baby better during the intervention.
Yeah. Thank you. Can I ask your parent to read out statement number 9, if possible?
Number 9, right?
Yes, please.
Okay. Neuroprotective strategies rely on the longitudinal monitoring of a panel of neurobiomarkers.
Thank you very much. And this also links to one of your conclusions that you said, hey, let's not look at one marker maybe, but a combination of biomarkers. Because if we look at the thesis, also some of this work dates back a few years. And yeah, if you, for example, would look at S100 beta in isolation, yeah, it's rather unidimensional, which could work, but at the same time, yeah, we now have a lot of, let's say, also computational power to link different levels of information and different types of biomarkers. So how do you see that? Can you think of how to combine different types of biomarkers in predicting outcome and also then deciding maybe to change treatment strategies?
Okay, we don't have selected biomarkers that can tell us what's the perfect strategy. But probably is possible in the future if we match all the data. There are no certainly data, but we have to match these levels with the clinical status. We are clinicians, I work in intensive care unit, so it's really important to see if the body is well perfused and in what condition is. If I can have another data that is a level of a biomarker that is alterated, probably I will change my management to avoid vasoconstriction, for example. When we have univentricular pathologies, anatomies, is really, really difficult to check the perfusion all the districts, because the body naturally protects his noble tissues, brain and heart, but the suffering of the liver, of the lungs, of the abdomen is not a good thing for these babies, even if they have the perfect brain on their head. So for the future, the matching of traditional biomarkers, troponin, proBNP, and so on, with new biomarkers can guide us, in my opinion, to treat them personally, because every anatomy in cardiac surgery is different from another, and these babies are little chronic patients at birth, because their physiology is totally different from normal physiology. And we have to, when a baby arrives, for example, in hypopulmonary flow, so I have the dependence of the pulmonary perfusion by the Botallo ductus, I have to check the cardiologist and ask him how large is the ductus, how many prostaglandins I have to give him to let the body well perfused and well saturated. In my opinion, if we can insert in this moment the neurobiomarkers, we can have support more to treat them well and send them better at the intervention.
Very clear, thank you. I'm very happy with your answer, and I give the word back to the prorector.
Thank you. We will continue the opposition with also a member of the assessment committee and now secretary, Professor Jos Maassen, with a chair in cardiothoracic surgery here at Maastricht University.
Thank you, Mr. Prorector. And yes, I read your work, your book as a general cardiothoracic surgery, and I thought I knew something about hypoxia during surgery, but in your profession it's completely different, much more complex, so thank you for that. And I want to congratulate you with your work, and of course also your Promotie team.
Thank you very much.
And before going to some questions, I would like to address, I was struck by it, your special training program. And I know treating children with congenital heart disease is considered as the Olympic in medicine, but you started with medicine, general, and then cardiac surgery and anesthesiology.
Yes, I wouldn't know.
Do you think that's necessary to be able to do this?
Yes, my course of study is long, but because I'm curious, so I hope to treat them in the best way possible. So I want to know more than possible about these babies.
Yeah, I expected that answer because on many spots in your book you say how important it is that children are treated in a multidisciplinary way, so as much as possible knowledge available. So you think this is a blueprint for future doctors? I
hope, because 90% of these babies reach adulthood. Mm-hmm. And for the scholar period and for their future as a professionist, it's important to be sane, not only with the heart that is functioning better. So we can improve in a lot of fields. First of all, at the arrival, and then when we sedate them, and when we put them on extracorporeal assistance, at weaning of CPB, and after the palliation. Because if we have a corrected baby, it's easier. Even if the compensatory mechanism that were present before the correction don't disappear immediately. So you have to fight with this other skill.
Yeah, you are also already preparing my next question. You think the intensivist, because that's your end station, your final destination, is the most important, men or women, in this treatment plan? Because the surgeon is only 4 hours, available anesthesiologist the same, and the intensivist is the most...
It's important, but is totally related with what happens in the operative room. Because, for example, the administration of cardioplegia has a vasoplegic effect on these babies. So even if I can't put a vasoconstriction drug in some babies, for example, a BT shunt, palliation, sometimes I need, but I can do this only if I check the low cardiac output syndrome, because the numbers by itself are not so significant. So if I see a good pressure, but I see that the baby's producing lactates, doesn't urinate, that pressure doesn't mean nothing. So for my management could be very, very useful, these tools, these biomarkers, and the officiality of these procedures, because even if we always say that the clinic is the queen in medicine, the science is the king, because the couple of these let us treat these babies in the better way and give them the better future possible.
Okay, that's already a bridge to the biomarkers, the main topic of your work. And as far as the why is concerned, you use it for risk stratification and early detection, but somewhere in I think in the third chapter you say we need that because there's a lot of difference in quality also between centers, and that's actually something that's very important discussion in the Netherlands. We have 18 million people, inhabitants, and 4 centers, and actually we want to go to 2 centers for children with congenital heart disease, but it's extremely difficult, and even people have come to court to prevent this. And when I'm well informed, in Italy you have 15 centers with 58.
We have 15 centers, probably. I'm not sure how many centers we have in Italy of cardiac surgery.
I looked it up, so it will be about 15. But what do you think? How do you agree that that's far too much? And how do you...
The cardiac center depends, in my opinion, first of all, from the surgeon ability, because as you can read in my thesis, the length, the duration of CPB and the surgical procedure.
But how should we judge that? Because that's one of the problems, the complication rate or the numbers.
Yes, we know that in our center the numbers of complications are lower than in other centers. Obviously, we can say absolutely that we are the best. No, it's not the sense of what I'm saying, but we are detecting in the last 10 years all these topics to improve our management. So, for example, our babies well monitored with the EEG continuous for 24 hours after coming out from the operative room. Before, only 1 hour to have a baseline, and 20 hours for. So we, for example, change our strategy. If the GFM goes down a certain level, we are going to open the chest, because even if I say
The
another...
point I would like to hear from you is it possible to use markers, for instance, to make a judgment between the quality of a center or of a surgeon?
In my opinion, not completely, because there's the baby. Every baby is different from another, but why not? The ability of the surgeon is quality of a post-operative period, surely.
Through registries, or how do you manage that in Italy?
I don't understand. Excuse me.
The comparison between centers and between the quality.
The comparison between centers, we are the second most important center in Milan of Italy, and the quality of our intervention is more complicated than in other centers, because we in our center arrive complicated case from the other countries, Tunisia, Egypt, Algeria, Romania. So we receive a lot of urgent babies that is impossible to treat in their countries, because our center is considered a very good center of reference for complex babies.
Am I still allowed to one question? Or?
Yes, a short question, and please a short answer.
The question is about the ideal follow-up time, because I think nowadays in adult cardiac surgery, we think, based on MRI studies, that brain damage with immediate results is one thing, but the long-term results after 20 or 30 years is becoming more and more important. Early Alzheimer, things like that. But I think in infants or in neonates, that would be...
In the babies is important and difficult, because the baby gives you, the neonate gives you not so much signs as an adult. So you have to follow him until the scholar age, for example, to detect the real damage, the real post-operative quality of treatment, in my opinion. Not only for the movement or for crying and eating, but for the superior function of the brain. And is really difficult. Is a topic, in my opinion, that is not so clarificable. Excuse me.
Okay, thank you for your answers.
Okay, thank you. The opposition will now be continued online by, again, a member of the assessment committee, Professor Fabio Galvano from University of Catania, and he's having a chair in biochemistry.
My first question, first of all, congratulations for your elegant presentation. And my first question is, I would like to know your opinion about the possible role of biomarkers in cyanotic and non-cyanotic heart disease.
Okay. They have a surely role, as I told before, for the management from the first time at the arrival, because in this moment we have only echocardiography and invasive data, so blood pressure or the blood lactates to evaluate their status. These babies are more delicate. They have usually an elevated hematocrit, so they live in a condition of hypoxic situation with a lot of blood cells. In this sense, we have to improve our treatment of these babies, for example, taking care of hemodilution, that is not so easy to tolerate for these babies, and taking care of the point of start of this clinical condition. So from cyanotic and non-cyanotic babies, there are several differences that bring us physicians to manage them in different ways.
Okay, thank you very much. The second question is to know your opinion about possible new strategies to improve the extracorporeal circulation in newborns with heart disease.
Yes, surely. We already changed our management of CPB in this population because before there was no difference in management of reoxygenation phase of CPB. Now in our center we produce a normoxic reoxygenation in these babies to avoid oxygen toxicity. Because as you can know, all the bodies, but these babies especially, are prone to lipoperoxidation, endothelial damage, and vasodilation with strategical changing of the perfusion of the noble organs. So when we act on these pathologies, we have to take care of what they do before. So for our management in cardiac surgery, we use normoxic reoxygenation after CPB, and after also in intensive care unit, we don't perform the modified ultrafiltration more, because before was performed for the hemodilution and for vasoplagia inducted by cardioplagia, but using nowadays the nidocardioplagia that let us to do less dosage and less frequent doses of cardioplagia in non-complicated patients, we have changed also this behavior for their treatment.
Thank you very much. I appreciate your answers.
Thank you.
Okay, thank you. Then we now continue the opposition with, again, a member of the assessment committee, and that's Dr. Marloek Kouwenberg-Raats. She has expertise in neonatology, and she's from the Maastricht University.
Thank you, Mr. Prorector, dear candidate. First of all, I would like to congratulate you and your supervising team with your interesting thesis and research. I'm a neonatologist with special interest in neonatal neurology. That's why I had a special interest in Chapter 2, and I would like to discuss it a little bit further. As I look at the table on page 29, then it seems that S100MB is the best biomarker at this moment. Could you further elaborate why it has potential in patients with perinatal asphyxia?
S100B is, excuse me, esteemed opponent. Thank you for the question. And as I showed before, in our review, it emerged as the best one because he has the most part of the characteristics that we search in these biomarkers. So he's present with a high sensitivity and specificity in brain damage. We can in base of the concentration establish the degree of injury and the length of the lesion, and is well known and well studied also in pediatric population. Not all biomarkers are studied. It's a more delicate population because it's difficult also for the committees that guarantee this population. So there are less data. And in our pediatric population, more or less, because they are so few, so special, so it's really difficult to collect data. And in this case, S100B is present and well studied in cardiac surgery before in the adult and now in the newborns and baby subjected to intervention. So is the best one for the brain injury, but is a good predictor with the adrenomedullin of ALCOS that in our field is interesting in the same way because ALCOS is not divisible from brain injury. The two things goes in the same way.
Okay. I saw that it was mainly excreted by the kidneys. Most patients with perinatal asphyxia also have renal failure. Do you know how this interferes with the biomarker?
Yes, because some biomarkers are produced or eliminated by kidneys, so the renal impairment can impair the dosage, the levels of biomarkers, but also the traditional biomarkers, just like troponin, has an impairment with kidney injury. So in this case, we have to take the data in a part and check with all the others clinical condition and consider also if all the data give us a precious message.
Okay. Then I have a next question. If you look at statement 6, you state that cardiopulmonary bypasses are planned hypoxic ischemic insult, whereas perinatal asphyxia has a complex pathophysiology and the timing is less evident. Could you advise me addressing the optimal timing of the measurements of the biomarkers?
I think that biomarkers in, as I told before, in cardiopulmonary bypass can guide us to the management. For example, we can reevaluate the level of deep hypothermia degree. If we could have a biomarker that tells us that the baby is not suffering, we can reduce the deepness of hypothermia. I can imagine for the future, because the hypothermic insult is not a good thing for these babies that are hypoxic and with the low temperature became more hypoxic because of the ligament between hemoglobin and O2 at low temperatures. So, in my opinion, biomarkers can guide us very, very well to change our clinical practice. And this is the most exciting aspect of this study, the applicability, in my opinion, for me that work on babies all day, every day. So I hope that these studies will give us a vademecum, a condition in which we can say, okay, S100B is high at this level, we have to cool the baby more or not.
Okay, and can you elaborate more about what is needed to translate it to the daily practice? Because at this moment we are not using it.
Is not easy to insert in daily practice for practical reasons. For example, the laboratory parameters and the laboratory management of these blood samples. But when you start a revolution, it's not so easy from the first time. It could be beautiful to insert for personalize the treatments on these patients, but in this moment I think that the system is not so ready to make this step. It can be used only in ultra-specialistic situations, but not in the routine, in my opinion. In Italy, we have good hospitals, but no one can let us perform this evaluation without study support. behind.
Okay, thank you very much for your answers, and I will give the word back to the co-director.
Okay, thank you. Then we continue the opposition with, again, a member of the assessment committee, Dr. Chiara Paila, with expertise area in neonatology, and she's from the University of Turin and present online.
Thank you, Prorector. Dear candidate, first of all, I want to congratulate you on your interesting thesis and very clear presentation.
Thank you.
My first question is, do you want to summarize what is the state of art specifically of S100 protein in cardiac surgery, current knowledge, potential areas of use, and especially future perspectives?
Okay, thank you for the question. S100 protein was studied some years ago, 15, 20 years ago, but then was abandoned for the confounding sources, not brain sources, but as I told before, for example, in our field, the thoracic fat, the pericardial fat, was abandoned, but now there's a new interest in this biomarker, for example, in my specific field, because we note that the high levels of S100B protein are strictly related to the dimension of the ascending aorta in hypoplastic left heart syndrome neonates, for example. So we can check the level of suffering at birth in utero suffering. So we can discover before we operate them how much he suffered before the arrival, before birth. For our surgeons, the dimension of the ascending aorta is the most important thing to make this palliation, because it means coronary impairment, it means brain impairment, and hypoxia in all the districts that we don't want hypoxic. It seems they are all the same. When someone calls us and tells us that he's arriving, was born in hypoplastic left heart syndrome, that is a very, very heavy pathology, we treat them in the same way. But their course is not the same, never, almost never. And probably we have to discover a lot of more things about these babies. First of all, how much they suffered during uterine life and at the time of birth. That is so difficult for a normal baby. These babies don't have half of the heart, so for them is more difficult. And so S100B is well known in cardiac surgery and is now used another time because other studies demonstrate that the impairment of fat, pericardial fat on the levels of S100B in the blood is not so important, so doesn't invalidate the concentrations, and we can evaluate that concentration as real and not affected by other sources.
Thank you. I have another question. In conclusion, which of the biomarkers evaluated may be the most useful in cardiac surgery, in your opinion, and why?
Thank you for the question. In my opinion, the most promising biomarkers are S100B, obviously, but adrenomedulin, in my opinion, can give us a lot of answers because when we have, for example, an ECMO assistance, that is another topic really important in our patients. When we have an ECMO assistance, we don't know, is completely hidden, the hemodynamical situation, the brain condition and the heart condition, because the machine works for all the organs. I hope that for the future, in these patients put on ECMO assistance, we can detect the levels and the behavior of biomarkers to let us know when is the right moment to reduce assistance, to remove assistance, because even if the pressure, the lactates, the urine output is good on assistance, the very significant the difficulty for me is the last part, the last 1/3 of flow is really difficult to win from the last part of assistance. So why? In these cases, in my opinion, if we can have the support of biomarkers, we can say, okay, is the right moment, or no, we have to wait because the baby is not ready to be weaned from the assistance. So I hope that for the future, these other patients that are as smallest population in a small population have a reasonably attention in this sense and were introduced in biomarker study to let us manage them in the better way.
Thank you so much. I have a last question, brief. Always in your opinion, which is the best structure of long-term follow-up for this baby? Time points, evaluations, what's your opinion in this field?
The best structure is surely neurological evaluation, because even if we have a lot of tools, so the continuous EEG or the NIRS or the laboratory values, the clinical status is almost always a surprise. We have got sometimes babies that in the numbers are perfect, but when you awake them, they are flaccid or are hypertonic or seems to be not contactable with the eyes and don't respond to noise or to visive stimuli, and you don't know why. So you sometimes do an MRI, but not always give us the answers that we expect to have. Sometimes we have to say to the parents, I don't know. They ask us, he will restore, and you have to tell them, I hope, just like you, but I don't know. And for me, is not a good answer, is not right for a doctor to give this kind of answer. So our follow-up has to be integrated of tools, laboratory values, and neurological evaluation, and rehabilitation if necessary, and the reevaluation after this phase of rehabilitation for restore neurological function.
Okay. It's fine for me. Thank you.
Thank you.
Okay, thank you. We do have only a few minutes, but we do have these minutes for a second round. Who may I invite for a next question? Anyway. Okay. Angela Satriano, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you very much.
sempre stato disponibile, lui alla fine questo non lo può negare, cioè, quindi si è trovato con un po' di difficoltà.
Oh mamma. Adesso ti devo dire.
Ora che devo fare?
Ecco, ricordati quando ti dirà do you promise, bla bla bla.
I promise. Ok.
Ti sposi con questa io ti terrò senza spaccare la ceramica.
Angela Satriano, the degree committee here present has assessed the quality of your thesis and of your defense. And in view of its positive verdict, and taking into account your previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor Gazzolo is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise.
Do you promise to work in accordance with the principle of scientific integrity at all times, to be careful and honest, transparent, independent, responsible?
I promise.
By the authority vested in us by law and in conformity with the decision of a committee represent, I hereby confer upon you, Angela Satriano, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the director, the secretary, and of the other members of the committee, and affix it with the official seal of the university. Congratulations.
Thank you very much. Ma io devo venire da te.
Dear Angela, the laudatio of 15 years of experience together should be too long. I want to summarize some major points. The first one, when we met in Milan with Alessandro, two promising cardiac surgeons. One remained promising, and the other one became a great physician, a great intensivist, and a good researcher. So 15 years of write a paper, close the paper, publish the paper, marriage, take a long time, 2 children, but one is Princess Julia, if I remember well, and a lot of time to let me to understand how the post-cardiac surgery evolves and develop a new strategy. The biomarker of 2012 are different now for 2025. And you were able to offer us a wide spectrum of a possibility for future study, future management of this kind of babies. What you say? You are a brilliant doctor. I trust you are a brilliant mama. And I have no doubt that you are a brilliant wives. And here is your family. So I think that it's time to conclude this period. What this is a baseline for your future might be. And I think that you have a good memory of what we spent together. and what perhaps we will spend in future time with other PhD from San Donato Milanese. We will see, okay? Now it's time to stop. It's time to celebrate. It is time that you think what you deserving, and this title is only for you. Best.
Thank you very much.
Dear Dr. Satriano, also on behalf of the University of Maastricht, I congratulate you, your family, with this degree, with this excellent defense today. And I also would like to congratulate the promotion team, Professor Diego Gazzola from University of Chieti, but also from University of Maastricht, Professor Luc Zimmerman from Maastricht University, and Dr. Danilo Gavilanes, also from Maastricht University. Having said that, I will close this session. And now over to the informal part. Online, they are not, I don't know where they are now, they should be on the monitor. But yeah, they are here. Yeah, to take a picture here in front of the desk with the two online opponents. And after that, we will move to the front of the building, or the entrance of the building with the stairs, and we will also take pictures over there. There is no final